So for this lecture, we're going to be talking about prognosis for MRI scans. The overview for today is going to be different from our past lectures. Today we're going to be talking about, the first three sections will still be the same. So we're going to be talking about what exactly is prognosis, what is it in simple terms, the importance of prognosis, as well as the fundamental concepts of prognosis. But unlike past lectures, this is going to be a lot more simple and a lot more about prognosis as an overview, instead of going in deeper depths into the mathematical concepts or the entire situation behind it, because prognosis is actually a relatively new field in medical imaging when applied to medical imaging. So what is prognosis? Let's take you through an example. Imagine today that you're visiting the doctors and you've already gotten your MRI scans and your blood tests and everything because you realized that there was something that was wrong. And so you went through all these tests and right now you're coming back to get an answer from the doctors. And immediately when you sit down, the doctors are like, hey, I'm sorry, but we've looked at your scans, we've checked all your tests, and it turns out that you have brain cancer. And this cancer is actually already too dangerous to operate on because it has spread to other parts of your brain. And from now on, it's only going to worsen. So physical activities will become increasingly difficult, and potentially you might only have a few weeks to live. And if you're lucky, maybe a few months. But right now, all we can do is give you treatment, but we can't operate and completely take the tumor out. And I'm sorry about this. This exactly is prognosis. It's allowing the doctors to tell you exactly what your life is going to be like because of a diagnosis that they've made, because of the scans that they've seen, because of the analysis that they've made. They're telling you what life is going to be like for you in the coming months and what procedures are going to come, including therapy and surgery in the coming months. So to summarize everything that I talked about, prognosis is predicting the likelihood or the expected development of a disease or of a diagnosis. So going back to that entire situation that we explained about before, the diagnosis was brain cancer, and what the doctors were telling you was what to expect in the coming months, including your therapy, including whether or not surgery is going to happen, and including how many months you have left to live and what life is going to be like for you. So in simple terms, we can see prognosis as a combination of many things that the doctors could potentially tell you, including whether or not the signs and symptoms will improve or worsen over time. So as I said in that very first example, the doctors were telling you that the brain cancer is currently way too difficult or way too dangerous for you to operate on, and your condition is only going to worsen from that point of time. And your quality of life. So for example, what activities can you do? Are you going to be bedridden for life? Are you going to be able to do intense exercises like you used to, such as boxing? What is it going to be like after your surgery or after treatments, if that's the case? And so there's also the associated health issues and complications, what you're going to feel. Are you going to feel nauseous most days? Are you going to feel exhausted? All these different things that the doctors are going to be telling you. In addition, they're going to tell you the likelihood of your survival. So how many months do you have left to live? Or potentially, if not even the likelihood of survival, maybe you are going to survive, but what is your life expectancy? Maybe it's going to come again. Maybe it's going to happen again. The tumors are going to grow again in a few months or in a few years. They never know. So what the prognosis tells you is whether or not these situations are going to be happening in the future, depending on your current medical history and depending on the current diagnosis and all the scans and results that have come out. So applying this entire prognosis and all the explanations that I talked about before to medical imaging, this is an example of what exactly it looks like when we apply or when we use medical imaging for prognosis. And so as you can see in this image, what we would have is, as you can see, short-term survival or long-term survival as we talked about before, so life expectancy. And these survival rates or these survival expectations are dependent on how we analyze these medical imaging or these MRI images. So in this case, as you can see, there was a lot more red parts. So a lot of the times, depending on these situations, depending on how, for example, the volume or all these different surface area kind of analysis of the tumors, they're able to kind of come to a conclusion on whether or not you would have a short or long-term survival rate. So going on to the second part, importance. So what exactly is the importance of prognosis? And I like to see it as it can potentially replace all the invasive techniques that we're using currently. So as you guys know, a lot of the times we do biopsies. So a lot of these invasive methods, in order for us to get a much better understanding of what exactly is going on in our bodies. And that happens a lot, for example, when we're trying to determine whether or not a tumor is benign or malignant. However, these potentially invasive techniques can be replaced by MRI images or by deep learning methods as long as we're able to implement these properly. So the challenges right now, or the impacts as well, currently you can see that for a lot of the times when we're trying to analyze or do prognosis, the doctors will look at tumor boundaries. So as we saw before, looking at that tumor, whether or not the tumor is potentially variant, or whether or not the tumor is big or small, or where the shape actually is. So whenever we label, because you gotta remember, we do this a lot for segmentation, for classification and registration, as we talked about before. We do all that, the doctors do all the labeling for us to have as ground truths. However, these labelings can be inaccurate sometimes. In addition to that, it can also vary per doctor. So a doctor may interpret this shape. However, a different doctor may interpret the tumor as a different shape. And potentially even a doctor may see the shape differently as he would in the morning or in the afternoon. So all these different kind of subjective perspectives on seeing the tumor boundaries can potentially lead to a lot of uncertainties when it comes to prognosis. So that's currently one of the challenges with tumor boundaries, or when we're trying to determine the expected outcome of a patient. The second part is feature extraction. So a lot of the times we look into these MRI images and we look at all the volumes, we determine all these surface areas, what exactly these tumors look like. However, each of these feature extractions can be extremely, extremely time consuming. You can imagine it as a doctor going through each scan and looking at each of these scans individually to determine exactly what this tumor looks like. And we'll see that, as you can see, from different perspectives. So for example, they would look at the MRI scan from the front perspective, or from the back, or from the top. So all these different perspectives will have to be collected, analyzed together in order for the doctors to be able to extract the features that they're looking for to make an accurate prediction. In addition to that, as I said before, varying opinions. Each doctor may have a different opinion of whether or not this feature looks this way or another way. So these subjective perspectives can actually create a lot of uncertainty around predictions. So in terms of tumor boundaries, if you think about it, when we apply prognosis to this, there can be a lot of potential impacts. For example, we can standardize this entire thing. So if an algorithm actually predicts this entire prognosis like very accurately, so if we have very accurate prognosis from this algorithm, then we would be able to standardize all these tumor boundaries determinations or all these feature extractions. In addition to that, it can assist doctors in analysis. So after extracting all these features, after extracting or drawing all these tumor boundaries, it is possible for the doctors to just go over it quickly, kind of confirm everything, and then be like, okay, well, this is what it looks like, and then explain the entire situation to the patient. The other part to it is also precise measurement. So as I said before, standardized, it's going to be very precise. A lot of the things that us as humans are seeing on the images may not be the same as the way that the computers interpret it. As we explained before, a lot of this is based on pixels. So computers see these images pixel-wise, whereas humans see it in its entirety. So by looking at the different intensity levels, it is possible that there's going to be a lot more precise measurements than us as human beings. And obviously, at the end of the day, it's going to be more comparable. Since all these answers are going to be the same, since it's coming out of one algorithm, it's going to be a lot more comparable when we're looking at different patients or when we're analyzing different data all at once. Second part to it, let's look at feature extraction. So the impacts of prognosis and feature extraction is actually very similar to the tumor boundary. It will increase the speed of analysis. So as you can see here, these may be different, these are different kind of images. So what you can imagine is that with each of these different images, you're looking at different aspects of the brain, and then you're analyzing the volume or like the surface area, and using all these different kind of features, including compactness. We would be able to collect all this information all at once in order for the doctors to be able to assist them in this whole prognosis process. In addition, as I explained before, it would be precise measurements in comparison to humans, where we're just drawing based on our own knowledge, our own experience, and what we see, which can potentially differ from time and per person. So talking about its application and its impacts. Prognosis can assist doctors in making therapeutic decisions and give patients additional information on their disease and their diagnosis. So the impacts of this is the fact that we're able to assist doctors in making better or more accurate predictions or expected outcomes in the future. And this also gives these patients a sense of an idea of what their lives are going to become after this diagnosis. So I wanted to talk about the current limitations of prognosis algorithms very quickly. One thing that I'd like to note is that prognosis is probably the most difficult kind out of everything that we've seen. And the reason for that is because for different organs and different diseases and for different patients, there's always going to be some kind of difference between each of these. So for an example, for different organs, there's going to be different methods of analyzing how their future is going to be like. For example, for brains, it may be within the next 6 months or the next few weeks that their life expectancy would potentially end. Or for example, for stomach or for lung cancer, it's going to be different from other, like for example, for breast cancer. So different organs would have different methods for a prognosis. Another thing to note is that for different diseases, for different locations, there's always going to be different kinds of analysis. So for some kind of brain tumor, it may or may not appear in certain areas. So a lot of the times we make predictions or diagnosis based on doctors' experience. So that's one of the amazing things that we're still finding kind of hard to, I would say, kind of replicate, because a lot of these things are based on a doctor's experience and knowledge. So for example, if a tumor doesn't usually grow in a certain area of a brain, the doctors may find this very abnormal or characterize that as a specific kind of tumor that may be different from what would usually be growing in that area. Another thing to note is that different patients would have different medical histories, and these medical histories can potentially impact the kind of prognosis that we're looking at. So when we talk about prognosis, we're talking about not one factor, but multiple factors that we need to add in order to kind of summarize this entire expectation or this entire outcome for the patients. So going on to the fundamental concepts of prognosis. For the pre-processing aspect of specifically MRI scans, which is what we're talking about today, I would say that it's the exact same thing that we talked about in segmentation, classification, and registration. So to re-jog your memory, pre-processing for MRI consists of 3 things that we usually go through. First one is MR bias field correction, second one is brain extraction, and third one, which is optional, would be registration. So re-jogging your memory on each of these, let's start off with bias field correction. What exactly it means is that for the same tissue area, you may have this like gradation of color that we see in this middle part. And this is called bias field. So going through after correction, what we would see is that the difference between this image and this image is the fact that you see this bright spot here, which you can see in this area. What ends up happening is that you smooth that area out. So you won't have this bright spot, which usually is detectable or considered as a tumor, actually, when it comes to deep learning models. And going on to talking about brain extraction, as we said before, exact same images as the previous lecture. So I would suggest you guys to kind of go over those lectures if this isn't clear enough for you. But what brain extraction means is that we're taking the brain out. So prior to extraction, what we usually see is this entire head. And this can differ depending on which angle or which MRI scan we're looking at of the head. And what ends up happening is that we create this binary mask in order for us to extract that brain so that we can only do analysis on the brain. And registration, last but not least, I would say that this is actually the most important in prognosis, and we're going to talk about a little bit more about why later. But registration essentially just means that we're looking at two different kind of images, and depending on what we're looking for example, for tumor growth, what we're going to be doing is that we're going to have this registration aspect so that we can combine these two images, make sure that they kind of overlap in the right positioning so that we're able to, I guess, analyze the difference between these two MRI images, which may be taken at different days or potentially even different modalities if that's what we're considering in the moment. So talking about the model training, so learning to predict the outcomes that we're looking for, including life expectancies. So what are some of the improved overall survivals associated with? So what this question means is what kind of aspects or factors do you guys think could potentially improve an overall survival for patients? So I'm going to give you guys like probably 10 seconds to think about this, and then I'm going to show you or explain what. So in simple terms, a lot of times we would consider our time, tumor type, tumor shape, your age, and your medical history. So what I mean by each of these is, for example, time. From when did you find, like, for example, early detection of this tumor? Or would it be a late detection of this tumor? So this time frame is actually very, very important because your tumor can actually turn from something that was benign to something that's malignant. So what I mean by that could be a tumor that was originally very small, something that could have been operated on and taken out completely, to something that was turned into a tumor that spreads throughout the body with time. The other kind is tumor type, which is basically what I said before, benign or malignant. The other kind is tumor shape. So what kind of shapes can determine what kinds of tumor we're looking at. And for example, age, we can expect due to biology, basically, our age actually has a very big effect on our survival rates when we are addressing different kind of issues. You can think about it as a common cold. So kids or people who have their immune system more or less just developed would actually have a much better survival rate than, for example, old people. So you can think of us, teenagers, or let's say teenagers would have a much better survival rate when it comes to colds. It may seem like nothing to us, but a fever can potentially impact an older person. And last but not least, medical history. Whether or not you've had this tumor before, or whether or not you have had different kinds of cancers before, or even just as simple as what other diseases do you have? Maybe potentially even genetics, or genetic factors that could affect the way that you react to, for example, this specific cancer. So if we're talking about this in more medical terms, we can see it as high levels of lymphocyte infiltration. So one thing to note about this, which is what I wanted to kind of re-jog your memory on the limitations of prognosis. One of the reasons why I said that prognosis is very, very difficult because there's a lot of uncertainties to it, and because for different kinds of cancers and different kinds of organs, there's always going to be a different kind of prognosis. So for a lot of different cancers, high levels of lymphocyte infiltration is actually a good sign of prognosis. So it's very favorable prognosis. However, when it comes to gliomas, which is a type of brain cancer, high levels is actually something that is frowned upon. It's something that is a red flag to a lot of doctors. So what I'm trying to get at with this is that a lot of the times with many different cancers, this kind of aspect or this correlation is actually very favorable. Sometimes there's also even no correlation, but there are situations like gliomas where it's actually unfavorable. So what I'm trying to get at with this entire situation is that prognosis has a lot of uncertainties to it that we will never be able to summarize everything in one algorithm. Other parts to it include spatial distributions of the lymphocytes with respect to the tumor. So where all these lymphocytes are with respect to the tumor can tell us like whether or not this therapy was working, or whether or not this tumor, whether or not this entire prognosis is actually favorable to us. Another thing is tumor boundary. So as we explained before, what does this tumor look like? What is the shape? And the tumor-associated stroma, as well as the number of new mets after therapy. So these are all the different kinds of factors that may affect our overall survival. So whether or not it's actually favorable to us or whether or not the prognosis is favorable depends on all these factors that we just talked about. So one thing that I'd like to note is that before we actually had statistical models. So prior to the analysis that we will be talking about in a few seconds, there was a lot of statistical models that were done on bigger populations. So you can think of a lot of prognosis as a prognosis that is based on the general population. So it doesn't consist or doesn't include of a lot of the individual medical histories that we were talking about. So it doesn't include the personalized part of medicine. However, there's a new method of approaching prognosis, and that's actually called brain metastasis velocity, which we're going to go in deeper depths later, as well as tumor feature analysis. So these are the two things that I explained before would actually affect our prognosis, or can actually improve our prognosis as new metrics. So what exactly is brain metastasis velocity? The units of it is actually metastasis per year. So you can think of it as that aspect as the velocity. So how quick are you growing these mets every single year? So that's the speed, or that's the velocity aspect of this name. So a lot of the times the time frame is very, very important. So how we set this time frame of this velocity is very important when it comes to prognosis. So each point of failure to whole brain radiotherapy or death. So this can be considered as one time frame that we would like to consider. The second one could potentially be initial stereotactic radiosurgery, which is a type of surgery we're going to go into deeper later, to the first distant brain failure. So a lot of the times we have seen that distant brain failure actually occurs after SRS, which is the stereotactic radiosurgery that I talked about just now. So calculating the time frame between this and calculating the BMV, which is what we're going to be calling it now, calculating the BMV between this time frame can actually be very beneficial to a lot of prognosis for patients with brain metastasis. And so a lot of the times they would be classifying it into three groups. So these prognosis models would be classifying these images into three groups. First one would be low, second one is intermediate, and third one would be high risk factors. And these can actually be defined by different kinds of doctors, which is what I was saying in terms of no standardization. But for most of the papers that are currently being offered or currently being reported, there was one that stated that the low would be considered as approximately less than 6 new mets per year. Intermediate would be between 6 and 15, and high-risk patients would be over 15 new mets the year after the SRS was performed on the patient. So, talking about treatments. So, the two treatments that I mentioned before, let's go a little bit deeper into that. So, the very first kind would be WBRT and the stereotactic radiosurgery, so the SRS. These are the two different kinds of surgeries or the two kinds of therapies that exist. And so for the past decades, WBRT actually has been the main method of dealing with a lot of these brain cancers or brain metastasis. However, recently, SRS has been the preferred treatment modality in patients with approximately 1 to 4 BMs. And the reason for this is because SRS actually provides better cognitive and quality of life outcomes with no detrimental effects on survival. So that's a very big part to it. There are no detrimental effects on survival. However, one of the drawbacks to SRS when compared to WBRT is the fact that it takes a longer time to plan this entire surgery. In addition, it's actually a lot more effort and potentially even cost. So that's one of the drawbacks to SRS. But overall, we've seen a lot more surgeries, SRS, in the recent few years. So going on to talk about brain metastasis, so let's see what exactly we mean. So at SRS, which is in this image, we can see that after the few weeks, you can see this tumor slightly decreasing with time. So at 6 weeks, it's basically gone. However, one thing to note is that it is very, very possible that at 6 weeks, even though that small tumor has become really small, there may be potentially new tumors that are growing in different areas of the brain. And so that's where the new METs that we were talking about before comes into play. So depending on the number of METs that are growing within that year or within the time frame that we have defined, we're able to calculate whether or not the expected survivals or the outcomes of this SRS is for the patient. And so one thing that I'd like to note is that there are many factors that actually affect BMV in general. So the very first one is histology. The second one is the number of METs at the time of the first SRS. So for example, let's say that at the time of SRS, there wasn't just that one blob that we saw previously. There were multiple. And in that case, it's actually very possible that that there would be more METs growing than there would be for a patient who only had one MET at the very beginning of the SRS. And the third one is the systemic disease status. And so all of these factors can actually affect BMV. So let's talk about the tumor shape analysis. So this is the second part, or the second kind of analysis that we're talking about when we're going through prognosis. So one thing to note about tumor shape analysis is the fact that there are two different kinds of tumors that we're looking at. So the very first kind, as I explained before, is a benign tumor. And it grows very slowly. It actually has distinct boundaries, as we'll see later. And it rarely spreads, so very, very rarely spreads. So in the case of benign brain tumors, a lot of the times we go through surgery. So you can imagine a doctor looking at an MRI scan, and they're looking at this one tumor that's on the scan that is very circular, potentially, and it has very distinct boundaries. So you won't see these very weird and abnormal shapes to it. In this case, they may see it as a benign tumor. And looking at it, since it doesn't spread, they know that they can operate on this tumor. However, one thing to note is that a benign tumor, even though it sounds very benevolent or very kind of a nice tumor, is that it can potentially be life-threatening if it is located in a vital area. So this is what I was talking about by there are tumors that specifically grow in certain areas of the brain. So as long as it's outside of that area, that's when they raise red flags for doctors, or potentially we're not even able to locate or analyze whether or not this prognosis is going to happen. And so another way to think about it is the fact that since a benign brain tumor is life-threatening if located in a vital area, we can think of it as outside of this area. If there is a tumor that has a distinct kind of shape, then it's very easy for this algorithm to be like, okay, this is circular, distinct shape, not within the area that we should be looking at, dangerous, red zone, may have a life expectancy of a few weeks. So this is a kind of prognosis that I'm talking about that is based on tumor shapes or tumor analysis. Another kind is the malignant tumor. And malignant, as opposed to benign, it's the complete opposite. It grows very quickly, it has very irregular boundaries, as we'll see later. And last but not least, it spreads to other areas of the brain. However, one thing to note is that brain cancer, unlike other kinds of cancer, doesn't spread to other parts of the body. So brain usually only goes to the brain and the spine. So nowhere else within the body. So what what kinds of deep learning methods do you think you can use in prognosis? So this is an open-ended question that I'd like you guys to kind of consider right now. And I'll give you about 10 seconds to walk through this. So think about these 4 components first, or if you guys are still kind of stuck on the deep learning methods, let's go back and talk about these 4 things. So first thing is tumor growth. Think about how this tumor is growing. Think about the second thing, which is the tumor boundary. So as we talked about before, is it distinct? Is it abnormal? And then the third part, is there any spread? Do you see it in other areas of the brain, or is it just located in this one big area? And last but not least, location, as we talked about before. So think about all these 4 aspects, and based on the 3 different kinds of AI methods that we talked about in the 3 previous lectures, what kind of methods do you think can be used out of the 3 in prognosis? The answer is actually all of them. So we're going to see in an example later how we can actually use registration, segmentation, and classification in prognosis. And this is the interesting part because you're tying everything in together into one, I guess, method, or into one aim or one goal that we're trying to get at. So registration, let's look at the tumor growth. This can be applied to tumor growth, and you'll see here how. So for example, let's say that this is pre-treatment and this is follow-up. You want to see whether or not this tumor has grown at all, or whether or not there are new tumors that are happening. So what ends up happening is that you can see there's a big tumor here, and this is pre-treatment. So let's just say there is a post-treatment, and this is the follow-up, maybe potentially weeks later. So what we're actually going to see is that this is where the tumor was originally, and you can see that it's still there, but it's getting smaller. However, one thing to note is that there are new tumors that exist in the exact same, or in the right area of the brain. And registration can actually come into play here, where you could combine these 2 images and overlap them, register them so that they're on top of each other for you to analyze how big has this tumor grown since pre-treatment, or what new tumors actually exist since pre-treatment. And it's a lot easier for you to register when you to analyze the image when you have these 2 images overlapping one another to identify these different locations. For segmentation, let's look at location. So a good way to think about it is, okay, we're looking at potentially only this part of the brain. So what you can do is that for each of these different images, what you can do is segment the brain. So we're not talking about the tumor itself, but the brain. So we're only looking at this area of the brain, whether or not it has spread, or as we said before, if there is a benign tumor that is growing in a vital part of the brain, then we'll know that there isn't a lot of time for this patient left. And so by segmenting this location and only specifically looking at this location, we can say, you know, there's a tumor right here, this is how it's going to be, and this is the result, this is the outcome, you don't have much longer to live. So that's where segmentation can come into play. Last but not least, we have classification, so tumor type. In this case, let's look at these 2. So this is what I talked about with the benign and the malignant tumors. So as you can see here, this is a very smooth and distinctive kind of boundary. And in this case, immediately by looking at it, you can say, not a lot of kinks, not a lot of these little gaps that you see over here. It's a benign tumor. We know that we can operate on this potentially if it's not as big as obviously this one. The malignant tumor, as you can see, we said it doesn't have any distinctive boundaries at all. So this is actually the entire tumor. As you can see, it grows very abnormally. It's very hard to draw a lot of the times, but that's just how a malignant tumor is. And by looking at it, we're able to classify as a malignant after segmenting it and being like, these are the features that this tumor has, So we're going to classify that as either benign or malignant, and using this results to kind of go through another classification process to be like, this is what prognosis, or this is the prognosis results that we're going to be getting from what we've classified the tumors as. So combining all the things that I talked about before, so as I said, we're not going to go in too much depth in terms of the AI or the deep learning aspect of prognosis, but exactly how medical imaging can be applied, or how MRI scans or how medical imaging in general can be applied to prognosis, how we can kind of speed up that process or change the entire process. And so first of all, we're going to choose that prognostic metric. So in our case, as we talked about today, we can do the BMV, or we can look at the tumor features, extract those features, and then identify. And after choosing our prognostic metric, we can choose our deep learning models. So in prognosis, there's actually multiple kinds of models that we can use, as there is for classification and segmentation. So there's CNN, there's DNN. So there's lots of different models that we can use. And after choosing that model, we're going to train the model. And this is where the next step comes in, which is the evaluation. So using our trained model to kind of give us that prognostic result. So this is the entire workflow, which is the same as every other evaluation workflow you've seen. So what we'd have after our trained model is we'd have our testing data set. It's going to go into our trained model. We're also going to have our ground truth in it to see how well our model worked. And we're going to calculate that model's accuracy, and then we're going to get our accuracy as well as our classified result. So our prognostic result from everything. So applying this an example, what we can see is, let's just say that this is an image that I actually showed in previous lectures as well, but it can be applied here. So as you can see, we have two different images here. And what we could potentially do with these two, since as you can see, these are very different tumors. So this one, as you can clearly see, is malignant. It doesn't have distinctive boundaries at all, whereas for this one, there's more of a round distinctive boundary. It's a lot smaller as well. So you can tell that person would have a lower life expectancy than this one. So this is what a doctor would do. You can see them looking through multiple of these scans and trying to come up with a result or a prognosis for the patient based on their experience and based on what they see. And so we're trying to feed this into the trained model that we had. And by doing that, we can create these masks. And in this example, we're extracting features. So looking at these features, what we end up having, comparing to the ground truth, we're able to define this as malignant and benign. And depending on the shape and the size of these tumors, we would also have another result that would tell us this person has a life expectancy of 14 weeks or 10 weeks, depending on the remaining of the data set that we fed in, or depending on the overall general population. So this is prognosis in an example. And so one thing, or a few things that I would like you guys to take away with, in addition to this overall general view of prognosis, is the limitations. And so the very first thing that we need to remember is that prognosis is a lot more accurate when we're statistically applying this to large populations. So you can see this in any kind of statistical kind of concept or method or situation, where the bigger your population, the better it is, because you're feeding in more information to give a better prediction for future cases. And the thing with biology is that there's a lot of things with nature that is actually very unpredictable. So we talked about the medical history. We've heard of a lot of stories where a cancer patient a cancer patient who survived cancer through some miraculous reason, even though the doctors have told him or her that he or she only has 2-3 months to live, and yet that ended up being 10 years. And so there are a lot of situations like this where I don't think even technology or even science can prove or explain. So what I'd like you guys to really take away from this is the fact that prognosis has a lot of uncertainty to it. Not even doctors can be 100% accurate. It's not like segmenting a tumor where we're just drawing the boundaries of what we see. In this case, we're predicting the future. We're predicting everything that comes in the future by our own experiences or by the data set that we only have currently. So this is something that I'd like you guys to remember. Biology is never going to be 100% explainable through science. You're always going to have all these unpredictable and unexplainable situations, and no technology, no advancement would ever be able to account for all these different situations. So that's something that I'd really like you guys to take away from. So going over the entire summary of everything that we talked about, or how prognosis applies in a workflow situation, we would have our input image as always, which is the MRI scan for our case. And we're gonna go through that pre-processing method that we talked about, the 3 different kinds. We're gonna feed that into the prognosis model training, train the model through ground truth, have our loss function and everything, come out, have the evaluation as we talked about towards the end, compare that with the ground truth in order to get the accuracy of our model, as well as our prognosis results. So what we would define or expect the outcome to be depending on the diagnosis that we have come up with. Thank you.